Hi, this is Peggy O'Connor, and this is a kind of final review of the unit on the acute respiratory disorders in children. This has been posted to Moodle, and it is a recap of the presentations that were presented in Moodle that you did as part of the flipped classroom, where you went through the lectures and then you came to class prepared to do case studies. And in class, you were broken into groups and case studies were worked on and presented to your classmates. And then we kind of reviewed and summarized at the end. And so now I'm giving you a final summary that you should pay attention to for studying for the exams, midterm, and final, as well as re-reviewing all of the other presented materials. So the first presentation that you had was about maturational differences between infants and children and adults. You've previously cared for adults. So infants and young children are obligatory nose breathers. They're diaphragmatic breathers. They have a much narrower and shorter trachea. So when there's inflammation, the inflammation causes a 16-fold reduction in the size of the lumen of the airway. They also have narrower bronchioles, and the same thing can occur. They have a funnel-shaped larynx, and their chest wall is too compliant, so that if the diaphragm is compromised, the chest wall, the muscles, the intercostal muscles, are too weak to lift the chest. Retractions are a result of an increased work of breathing. Respiratory rates are normally higher, and the eustachian tube is shorter and horizontal. So the essentials of a respiratory assessment include assessing the infant or young child's interaction with the environment. The nurse should be doing this as they're entering the room. Is the baby paying attention to the mom? If it's a 1-year-old or a 15-month-old, and you as a nurse who the baby doesn't know, under normal circumstances, the baby should be expressing separation anxiety, and if they are not doing that, if they're just kind of lying there listless in the bed, then one would be saying that their interaction with the environment is diminished. You want to assess the respiratory rate. You want to listen to breath sounds. And where would you listen to the breath sounds on an infant? You would not listen to them in the normal places. You want to listen to them on the midline of the sides. You want to assess color, the respiratory effort. Are there any adventitious breath sounds such as stridor, wheezes, crackles? What are the respiratory mechanics? Is there any nasal flaring, retractions, or grunting? And what's the hydration status? And the best method for measuring hydration is the daily weight. In providing nursing care for a child who has tonsillitis, before surgery, the nurse should ensure that the child has no signs and symptoms of tonsillitis. And after surgery, the key points are to make sure the child drinks plenty of fluids and has no milk products until 48 hours postoperatively. Tylenol or acetaminophen should be administered every 6 hours around the clock. It is possible for them to use an ice collar, and there should be no suctioning or sharp objects used in the back of the throat. Children can outgrow this tonsillitis in their school age years. It is generally the first line of treatment is antibiotics, and if that doesn't work, then they do surgery. The key is to watch for postoperative bleeding, and those signs would be swallowing frequently, so we want to have them kind of avoid swallowing a lot, avoiding sharp objects, and introducing milk products on post-op day 2. We want to promote decrease in swelling, so make sure that they're cool, soft fluids. Bleeding is considered a medical emergency, and it is collaborative treatment, either medical and or surgical. In providing care for a young child with croup, we want to make sure that we keep the airway open. And so in order to do that, we want to keep the child calm. We want to make sure that oxygen saturation monitoring is done at all times, and they may need oxygen to keep their oxygen saturation greater than 93%. For medications to be administered, nebulized racemic epinephrine, corticosteroids, either IV or PO, and keep them well hydrated, and that may mean IV fluids for a period of time. The goal of treatment for a child with croup is to maintain the patent airway, so that is done by monitoring either ABGs or pulse oximetry, and we want to minimize crying because that will aggravate airway obstruction. If in triage, the nurse receives a phone call where the child is suffering from stridor at rest, has cyanosis or severe agitation or fatigue, and has moderate to severe retractions or is not drinking any PO fluids, they must go to the emergency room. Do your respiratory assessment, and treatment will include racemic epinephrine, IV and or oral dexamethasone, which is your corticosteroid, and it will be switched from IV to PO. Humidified oxygen while they're in the hospital, and you should have intubation equipment nearby. Treatment for bronchiolitis, isolation. You can room 2 together. Humidified oxygen to keep O2 sats greater than 90%. Hydration is usually intravenous and then PO because they're not able to drink. Nasal suctioning, chest PT is ineffective. Hypertonic saline nebulizers, albuterol nebs, are ineffective. CPAP and stay in the ICU for moderate to severe cases. And the best treatment is prevention, and that would be prophylaxis with intramuscular palivizumab or Synagis immunizations. This is a bronchiolitis score, and so you would score a 0, a 1, a 2, or a 3. And then depending on the respiratory rate, if it's under 30, there's 0, 30 to 45 is a 1, 45 to 60 is a 2, and if the respiratory rate's greater than 60, they get scored a 3. For retractions, a 0 for none, 1 for only if they're intercostal retractions, a 2 if they're intercostal, subcostal, or supraclavicular, and a 3 if you see abdominal retractions or the seesaw respirations. For nasal flaring, a 0 for none, 1 for mild and rare, 2 for moderately severe and intermittent, and 3 for severe and continuous. For wheezing, 0 for none, a 1 if it's heard only with a stethoscope, 2 if it's heard on expiration with a stethoscope, and 3 if it's heard on expiration without a stethoscope. And then their general status, if it's normal, it's a 0. If they're moderately uneasy or occasional cry, they get a 1. 2 if they're very uneasy and have a continuous cry, and a 3 if they're lethargic. So this is very useful in being able to tell how sick the child really is. RSV prevention can be done either with RSV immune globulin, which is a monthly IV infusion, or the more common palivizumab, which is a monoclonal antibody given as a monthly IM injection to at-risk children. So summary for bronchiolitis, we want to maintain the patent airway, and we want to do our respiratory assessment. So looking for the rhinorrhea, they're going to have a tremendous amount of clear, copious nasal secretions, and that will progress to an increase in cough and wheeze, air hunger, and retractions, and you may see their respiratory rate more than 70 breaths per minute. They may become listless, apneic, and have retractions and nasal flaring. Nasal wash for the ELISA test, and then the treatment is humidity, hydration, and rest. We use nebulized hypertonic saline. They get oxygen via nasal cannula, nasal suctioning, and elevate the head. The summary of acute otitis media, it's acute onset and there's marked redness of the membrane. If it's recurrent acute otitis media, they have repeated bouts of AOM. It's generally 3 times in 6 months or 4 times in 12 months. OME is otitis media with effusion, and that is fluid accumulation with no inflammation, and it's generally related to allergies. And then there's chronic otitis media where it continues for 3 months and the child does have a hearing loss. So acute otitis media usually follows an URI. They have an earache, fever, and purulent drainage. The diagnosis does require all of the following: that it's a recent abrupt onset, middle ear fluid, bulging membrane, and signs and symptoms of the middle ear infection. Treatment is generally watchful waiting for 72 hours, However, that is not recommended in children under 2 who have acute symptoms of fever and severe ear pain, and also all infants under 6 months with acute otitis media must have antibiotics. If they need surgery, it's going to be a myringotomy and tympanostomy tubes and possibly an adenoidectomy. And the tympanostomy is usually used to treat recurrent otitis media. So chronic otitis media does cause hearing loss, and they may have difficulty communicating and have tinnitus. They will have an adenoidectomy if it's chronic with nasal obstruction. Otitis media with effusion, antibiotics are only ordered if the OME lasts more than 3 months, and you have to use a pneumatic otoscope to differentiate acute otitis media from OME when you're assessing the tympanic membrane. And the last part is pharmacology review. I've kind of touched on that with each of these, but generally if it's a bacterial issue, antibiotics will be ordered. If it's a viral issue, there will be no antibiotics ordered. Racemic epinephrine is only used for upper airway inflammation. Albuterol would be used if it were a lower airway situation. And corticosteroids, either PO or IV, is used for severe croup. Synagis or palivizumab immunization prevents bronchiolitis. So this is the end of the nuts and bolts of what you should be reviewing for the respiratory lectures.